Test 1, 2, test 1, 2. That looks good.
Did somebody just join us?
Question.
And Steph, one thing you can do on this, I don't know if you saw or not, but for this type of go-to-meeting, people have to mute themselves.
Okay.
So there's no background noise. Otherwise, if someone does start talking for some reason, and you know, you want to politely mute them, the column on the left with the microphone, if it's green, if you you can touch on it and it'll override them, and you'll be muting them.
Okay. Sounds good.
You couldn't hear me when I said that, right?
Nope.
Okay. So I can't do that. So what we want people to do is to mute themselves, and then they have questions, unmute, and I have no problem going through questions anytime during the presentation. We'll do more at the end as well.
Sounds good.
But I think we should probably get started.
Is it just the Breidenbachs that are on here so far?
Yep.
Is there anybody else? No? Right, would you like to get started?
Well, it's 7:32.
Somebody's popping in. Hang on a second.
Phone. So, Steph, you can go ahead and talk about the muting, and then unmute to ask a question. Also explain this is going to be recorded.
Yep.
So anything they say will and can be used against them. Dr. Mark.
Hey, Dr. Mark. My Swiss Bear isn't on quite yet. I'll wait for him to join us. I can start.
Okay. Always takes longer to get in hooked in with GoToMeeting. Sometimes they have to download it if they haven't done it for a while. Okay, let me know when Mark arrives.
Sounds good.
Can you hear me?
Yep.
This is Ashley. I'm Dr. Mark's CA.
Oh, hey, Ashley. How are you?
Hi there. So I'm going to be recording this for him. He's currently in at the moment.
Oh, okay. Sounds good. All right. Well, I think we are. Do you want me to get started?
Yep. Let's go.
Okay. So, Ashley, if you don't mind muting your phone, just so we don't have anything going on for right now, and then after Dr. Wogan's done talking, we can unmute you guys and let you answer or ask any questions that you may have. And I would like to thank all of you for joining us tonight, because we do appreciate each and every one of you. And Viper Health is around for all of our clear doctors, so we can be essentially a one-stop shop for you all with the best equipment. Tonight we are going to be talking about the new Hoodweight. and the anterior chest weight. And for those of you that have joined us tonight, there will be free shipping on your first order within the first 24 hours after this meeting is over with. And I can give you pricing too here afterwards if you would like for all of them, unless I'm going to do it now. But I will let Dr. Wogan speak. Let's see. He's going to explain how the Hoodweight works and how you can utilize and incorporate it into your clinic. So without further ado, I will introduce you to Dr. Dennis Wogan.
Thanks, Stephanie. Good evening. This first started back in January of this last year. We were out at Vegas at the Parker Seminar, and Dr. Scott Flavel, who's the, not Dr. Scott Flavel, who's the guy that makes the headweights, came up to me and he said, I've got a friend of mine who's a savant, and he's a very intelligent person, but he can't communicate well with other people. But he had this idea of doing a Hoodweight, okay, which we see right here. But what he wanted to do was keep that person in a super extension. And what happens if there's anterior longitudinal ligament instability, that can cause a loss of motion segment integrity with the vertebra. In other words, the slippage anterior and posterior of the vertebra. So I put it on and I said, well, if we work it on the front, it works these flexor muscles much better. And I thought that was a pretty good idea because I could really feel it working. And then Josh came along and said, well, let's throw an anterior chest weight on there too and see what happens. And I said, yeah, I think this is going to work, but what we're going to have to do is DMX it and find out. So I came back with the idea and started playing it. This is Teresa. So the hood weight goes up on top, and then the anterior chest weight comes down in front. Here's another picture we can see from the back. What we're getting here is an opposing force. We've got the cervical roll pulling frontwards, and then we've got the chest weight here that is making the body react backwards. And it seems to be very effective. Here we can kind of see a front and back picture with the mirror at the same time. So we're getting opposing forces with this. Now, I would say that 90% of the time with patients, we've had pretty good results with the head weight, the therapy glasses. And there's always been some, and you'll see some examples of that just didn't respond the way I wanted to see. And we tried the backpack, but that really didn't work that well. And I think this is really the answer to restoring the very difficult cervical lordosis. Dr. Paul King was at my clinic a couple of weeks ago, and we did a DMX on him. Found out that he had a kyphotic neck with 122% loss of curve, which gave me the perfect subject to experiment on. So we actually did a DMX on Paul. So I could start to see that the lordosis was starting to come back in here, and I like that, especially with Dr. Paul. So we took an x-ray, and this is what we did is we put a 5-pound head weight on him and a 5-pound anterior chest weight, and it took it to a 16% loss of curve, which is pretty good from a kyphotic neck. Then we just went with the anterior chest weight and a 4-pound head weight. So this is the head weight, not the hood weight. We're at a 61% loss of curve. Then we went with a 10-pound hood weight and a 10-pound anterior chest weight, and if you look, it's still at a 16% loss of curve. In other words, 16% loss of curve is a really good reduction. It's a very good change, but doubling the weight didn't make any difference. So as we started to study this over the last couple of weeks, since Dr. Paul was there, I started to look at some other cases. This is a patient of mine, a very skinny girl, and not a lot of muscle mass, but she had a kyphotic S-curve, kyphosis up on top, lordosis in the lower back. I've probably done about 25 to 30 DMX studies on this. So we can see the kyphosis, lordosis. Now this is a weight all the way around, which is the Halo Rejuvenator. No change at all. Still kind of straight in the upper area here. A little bit better lordosis here. Now that brought the curve back real nice in her neck. Now, because she's so small, what I did is I just used a 2-pound hood weight and a 2-pound anterior chest weight. Okay, same thing, sorry. Okay. So this is with the Halo Rejuvenator, still a kyphotic S-curve. This is with the hood weight alone, and it's still a bit of a kyphosis. It's improved, but there's still a kyphosis in the upper cervical spine. When we put the hood weight and the anterior chest weight together, we can see how it brought that lordosis in. So that's a key finding to this. This is another patient of mine, about 40 years old, and just a real difficult neck that we've been trying to get to change. Again, completely kyphotic, and we'd work on him, get the curve back in. Every time we returned to the clinic, he had a kyphotic neck. Oh, so he's got the kyphotic neck. We actually put him on a pillow. So even with these supports, not a lot of change. This is a tempura pillow that he brought. Head tilt. That worked much better. Kind of straightened it all out. What that really was showing, that line on the back really wasn't changing, or using any type of cervical support wasn't changing. Especially with your standard pillow, it doesn't really. Most pillows, your standard pillows, when you lie on them on your back or supine, it actually it reverses that cervical lordosis, and we're able to fix some side sleeping here. Okay. Now. So when he did the hood weight and the anterior chest weight with him, it actually brought it to a 47% loss of curve from a kyphosis. This is Beth Butler, 164% loss of lordosis and then a kyphosis. So again, lordotic kyphotic S-curve. She also does a lot of down work as an accountant. So this is keeping the force in the lower neck, but there's no opposing force. Again, it improved the upper lordosis, but not the lower kyphosis. Now that started to bring the curve back real good. So just with the hood weight alone, she was at 160% loss of curve. You're going to find the hood weight almost has a compressive force. We don't want to use too much weight with that. The anterior chest weight actually did a lordotic kyphotic lordotic buckling. That was a 213% loss of curve. We did the hood weight and anterior chest weight, both were 10 pounds together, took it to a 20% loss of curve. Now, this is Chelsea. This is the wife of a chiropractor, and I've been working on her for 4 years, trying to get her the curve back in the neck. And we've had quite a difficult time with her until now. So this is a DMX of her back from 2010. You can see the severe loss of curve. and a lot of instability here. 2, 3, 4, 5, 6, 7. Okay, and slippage here as well. 2, 3, 4, 5. 3, 3, 4. And then just reverses again. So we had quite a time with her until we came up with the Hoodweight. So we took it off and the posture stayed there. He goes on to say, it's a good thing that you married me, because if you hadn't married me, you wouldn't have met Dr. Wogan, who fixed you. Okay, so this is like without the Hoodweight and the headweight on after she wore it for a while. And after 2 weeks, she came back and she was still at a 61% loss of curve. So this is the post-DMX without the headweight. In other words, the curve is staying, which I really am happy to see. This is a chiropractic student that came up from Northwestern. His name is Ben. He had a kyphotic S-curve. And with the anterior chest weight, it took it to a 34% loss of curve. And that's really pretty good. We can see the picture down here in the lower left. When we did the Hoodweight with him, we kind of got upper cervical lordosis, very straight military neck in the middle, and then a lordosis in the lower back and the lower neck, which would be a 126% loss of curve. When we needed the Hoodweight and the anterior chest weight together, we took it to an 18% loss of curve. And this is after doing the Vibe for 5 minutes and then coming back, and it was still on, but then he was down to a 5% loss of curve. And then 15 minutes after that, we did another DMX without the Hoodweight and headweight on. He was still at a 34% loss of curve. So we're really looking for his long-term results with this. And then here, you can just put in the therapy glasses on. Seems to help hold it in place. This is Michaela. But it increased the forward head posture. Much better. So actually, with the Hoodweight and the chest weight on together, took it to a complete normal cervical lordosis. Since then, I've been working a little bit more. This is a patient that I just started working on a week and a half ago. She presented with a lordotic S-curve, a lordotic kyphotic lordotic S-curve. So she's got a lordosis, kyphosis, lordosis, 295% loss of curve. Now, we did a 3-pound head weight with the therapy glasses. It decreased the forward head posture, but we're still at a 203% loss of curve. It took it from a lordotic kyphotic lordotic neck to a lordotic kyphotic neck. But that's not what we want to see. So then I went with a 10-pound hood weight and a 10-pound anterior chest weight, and the upper cervical curve buckled, a good lordosis, but the lower neck here actually buckled into a kyphosis. So what I started to realize is that it was just way too much weight for her. We can't go 10 pounds standard with these patients. So we changed it to a 5-pound hood weight, which had a less compressive force pushing down, and then just a 10-pound anterior chest weight, and that brought it back to a normal lordosis. So then we got a normal curve back in her neck, and this is actually without the head weight and the hood weight on. So I'm starting to see this staying much longer. They're going to have to be doing this at home for about 15 minutes twice a day. Now, I want to come back here. The other thing that I'm noticing is when you look at this one, there's a lordosis up on top and a kyphosis in the lower neck area, especially this area here. The size of the roll here makes a big difference. I started using a 3-inch roll, but sometimes that wasn't allowing the upper cervical lordosis to come back in place. So now I'm primarily using a 2-inch roll down in the lower neck area. And that's given us a better, kind of a smaller fulcrum for the hood weight to work against. And so pretty much for your average typical patient, I want to use a 2-inch roll in the back. For someone who's really tall, say above 6 feet, we're going to use a 3-inch roll. But the 2-inch roll seems to work better. So 2-inch cervical roll. I'm not sure if Viper Health has these, but it's a 2-inch foam. And then washing machine drain hose is really flexible. I was able to find some at Walmart because they're the only store open at 5:30 in the morning when I go shopping. But the washing machine drain hose, it's what drains the washing machine into the sink, and it's really flexible hose. I think for most patients, you want to start with a 5-pound hood weight and a 5-pound anterior chest weight and see how they respond. Now, if it's a smaller patient, I definitely want to maybe start with 2 or 3 pounds, front and back equal. If I'm starting to see the cervical lordosis buckling and not the thoracic kyphosis, what I'm going to do is probably increase the anterior chest weight and decrease the hood weight. I'm finding that if anything, we want the hood weight to be equal or less than the anterior chest weight. If we start to see that neck buckling like we just previously saw, we definitely want to decrease the hood weight. I also want them doing this on the Vibe or on the air disc at home or both. It works better when